Welcome to the Healing Health Podcast. I'm Amber Petty. In this episode, I'll be talking to Associate Professor Martin Hensher from Deakin University's Institute for Health Transformation. We sat down to discuss his research on how Australians are over-medicating and over-consuming our healthcare services. So join us now in the conversation. Well, firstly, hello, Martin.
Hello, Amber.
Thank you for agreeing to have a conversation with me about something that I find very, very interesting. But I wanted to first start with, you are a person that has a very impressive CV, and I would like to just have a little discussion about that before we get into your research. So I'm told that you've worked as an economic advisor to health departments in Australia, the United Kingdom and South Africa, and as a consultant for the European Commission, the World Bank and the World Health Organisation. Is all of that true?
That is all true, yes.
Okay.
As charged.
So tell us, what is health economics all about?
Economics and health economics over the past, let's say, 20, 25 years has become increasingly important for health systems all around the world. Everybody really is battling with the same problem, which is we could spend as much money as we wanted on healthcare, yet there would still be more things we could do. There would still be more treatments. And so a key question, even in the wealthiest countries of the world, really is, are we making sure that our spending is efficient? Yeah. Is it being allocated to the best possible uses? Are we getting the best possible outcomes that we can for every dollar spent? So that's very important even in a country as rich as Australia. And you can imagine in low-income countries and developing countries across the world, it's even more crucial. Every dollar wasted or every dollar spent on something which has less impact on people's health is a dollar that could actually have saved lives elsewhere. So economics has become increasingly important in healthcare, and particularly national governments therefore need to have specialist advice on economics, but from people who understand healthcare systems. So people who have a kind of deep knowledge of health and healthcare. And I've been incredibly fortunate by, if I'm really honest, at the beginning, an almost accidental process of ending up having just an amazingly interesting and fulfilling career doing that.
Wow, you've had an incredible career working all over the world in all sorts of interesting capacities. You're now here as a lead researcher at the Institute of Health Transformation for Deakin University, and the research you're doing is looking into Australia's overconsumption of healthcare and overtreatment. What does that actually mean? What is that looking at? What is that saying?
For sure. Okay. So I think for many years, people have had a suspicion that sometimes we are providing care to patients that they didn't really need.
Yes.
Okay. that would is not really offering them any benefits.
Yeah.
Okay. And there are all sorts of things that can make that happen, ranging from, the sheer sort of profit motive of let's, do as much as we possibly can, through to...
Is that for drug companies?
Okay,
who benefits with what you're just sort of saying there?
All right, so across the board, and I think I'll kind of carry on with what I was going to say. Before we go back, before we defame anybody too much. So what I was going to say is, the reasons why this might happen range from simply making money by selling more stuff, as in any industry, through to, at the other end, really the very best of intentions of believing that we want to offer the very best care for our patients, and that clearly involves giving them every possible option that we possibly could do and doing everything for them just to be on the safe side. So it can range from the mercenary to the completely well-intentioned and altruistic.
This is what the lucky country looks like.
And of course, those things can merge in the middle.
Yeah.
And this problem of there are two parts to this problem, if you like. One is called overdiagnosis and one is called overtreatment. Okay, so the overdiagnosis part of this problem occurs when patients are diagnosed as having a disease or having a condition, and they do indeed have that condition, but that condition was actually probably never going to make them ill. Okay, so a great example of overdiagnosis comes, in a really extreme example, comes from South Korea. Okay, and thyroid cancer, so cancers of the thyroid gland. All right, in basically once first CT scanning and then MRI technology began to become available on a large scale. For reasons that are still not really understood, but in South Korea, doctors became very enamored of screening people, giving people CT scans to see if they might have evidence of thyroid cancer. And once they started doing that, they started diagnosing ever greater numbers of people as having thyroid cancer. And as a result, lots of people started having surgery on their thyroid glands, which is quite nasty surgery because of where it is and with all sorts of horrible side effects, etc. And the numbers of people getting this treatment went up and up and up, so that South Korea has rates of thyroid surgery sort of, 5-6 times higher than other comparable countries. Yet the death rate from thyroid cancer remained unchanged all the way through this period. So even though they were operating on more and more people earlier and earlier, they actually weren't saving anybody. Because in fact, they were operating on people who were not actually ever going to become sick, far less die of thyroid cancer. And another good example, which is more familiar to people in Australia, is this is more complex, but the very complex issue of prostate cancer. So what we know about prostate cancer is that it is, for men, it's one of the most common forms of cancer, and a very significant proportion of men who die in old age will, on autopsy, have evidence of having prostate cancer, but it wasn't prostate cancer that killed them. And prostate cancer actually, it absolutely does kill men, and there are many men who do require the proper treatment for it. But most men who have prostate cancer, it will not be that actually does for you in the end. And again, prostate cancer treatments, they're getting better, but they are quite invasive. They have difficult side effects, uncomfortable and kind of reducing quality of life side effects. So there are very complicated trade-offs to be had, but there is often a tendency that as soon as we've got a new technology, we just want to use it more and more on as many people as possible. The problem with that is that for most technologies, initially, they're highly effective. As we begin using them on more people, they initially, once we've worked it out and we get it right, they're very effective because initially we're using it on the sickest people who most need it, objectively really need it. But then what we tend to do is we tend to give it to more and more people who are less acutely sick. And
is that because it's creating a lot of fear and talkability? So people are going, you need to go and check that out, as if it's something you're more likely to have?
Well, so look, we do see that with some diseases, and particularly cancer. There is a great tendency for the very best of reasons, that we want people to be aware of cancer and we want people to get early diagnosis, and that can quickly spiral into a bit of a panic. At times, and it can kind of get whipped up. But often it's not even that. It's often actually much more to do with clinical practice and kind of clinical norms. What is what are doctors in a particular specialty? What's their kind of current idea of what should I be doing for people?
And what's, I guess, exciting them too.
Exactly. And technologies move very fast. Exactly.
Yeah.
If the guy down the road has now got the machine that goes ping, well, I want one too, because I want to clearly be at the top of my game. But also, particularly in the pharmaceuticals sector, drug companies, again, quite reasonably, they invest in marketing their drugs to doctors, so they will invest quite heavily. And one of our I think a real kind of paradox that as a society in Australia, and it's the same is true in all developed countries, is we quite rightly, we want to prevent disease. Of course, we want to prevent disease, and that's absolutely right. And we want to intervene early before people actually get sick. So even if you can't prevent somebody getting something, let's intervene early before its effects have become too bad for that patient. And that's completely reasonable. But that often has kind of takes on a momentum of its own. And we see that in many areas, that drugs are introduced initially to treat people who are very sick. Then they start expanding their use into people who have the condition but are less sick. So they're used in a kind of ongoing management way. And then the next threshold, which we see in a lot of cases, is we then have the bright idea of, well, maybe we could use this to prevent this condition. So we start giving them to people who actually don't yet have the disease, but maybe show some risk factors for whatever that disease is. And of course, then once we're starting to use pharmaceuticals in particular as preventive programs, we might actually then be handing out drugs to possibly millions of people, certainly hundreds of thousands. And this is where the real problem at the heart of kind of overtreatment and overconsumption comes, is that when you're sick and when we're concentrating our treatments on the people who are sickest, we tend to get a lot of benefit. And the side effects and the adverse effects, which come with all treatments inevitably, if you're already pretty ill, it's entirely reasonable to take your chances on even quite nasty side effects. That's absolutely reasonable.
You haven't got a lot. You've got a lot.
Exactly.
You haven't got a lot to lose.
Nothing to lose.
You've got a lot to lose.
And a lot to gain. Look, it might go wrong, but in the extreme, if you were going to be dead anyway, well, why not?
Correct.
So that's absolutely reasonable. But as we start treating more and more people who are less and less sick, for most adverse events and most side effects, the risk of having an adverse event is the same whether I'm really sick or completely well, because, I'm giving you a drug which, for example, might have some small risk of causing a heart attack. So that risk is constant for everybody. The benefit is very big for somebody who's very sick. But if I'm really not very sick at all, or not sick, just have some risk factors, I've still got that, whatever it might be, 1 in 1,000 chance of a heart attack as a side effect.
Which I've just upped that I didn't necessarily have.
But I didn't actually, but this drug is not necessarily giving me any benefit at all. So, and the more people we do these things
that
in,
it bleeds into,
obviously the bigger the harm that is actually coming out of the healthcare system.
Partnering with businesses big and small, Deakin offers world-class research and development expertise, first-rate facilities and global leading talent to develop game-changing solutions. Ranked in the top 1% of universities globally, Deakin is a world leader in research across multiple industries. Whether it's tackling the challenges of health systems in society, developing future materials for a circular economy, or shining a light on a brighter energy future, Deakin Research can take your business to the next level. To find out more, head to deakin.edu.au/collaboration. Deakin, more than a university.
Are you seeing out of your research who is the percentage most likely to blame for that happening? Because, again, me not being educated in this area, as an average person, I think, okay, so there's the doctors over prescribing, which there must be reasons for. I don't know, like, okay, I'm going to sound really judgmental here and say, is that a generational thing with some GPs and health specialists? Because my personal experience is that's what I've seen. Much more quickly, an older GP has been sliding across a prescription to me, and I slide it back and say, I think we've gone a little early on that. Then there's obviously people who, have different programming and fears. If I grew up with a fearful mother about health and, wellness, then I'm probably going to end up a bit of a hypochondriac. So I'm probably more likely to go than my friend who didn't grow up with that mother. So there's those sort of contributing factors. And then, of course, there is the drug companies going push, push, push. So I want you to sort of respond to that little triangle and add any, any other kind of perpetrators that I don't know of. And then I want to talk about who gets to sign off on these drug companies getting the green light.
Okay. So great questions. Let me try and turn it around a little bit. Mm-hmm. So I think it is it's not really accurate, let alone fair, to sort of say how do we attribute blame here? Mm-hmm. But absolutely, let's talk about causes and the forces which are at work making this happen.
That's a better word that I should use. The forces.
If we want to use blame, yes, we should probably get the solicitors department in first. But it's more complex than that. So look,
sure.
This this is really one of those truly systemic issues. Okay, so there's no particular actor or set of particularly bad actors who are just driving this for their own nefarious reasons.
Yes.
What you have is a whole system of healthcare, so both the kind of, let's say, the clinical model of healthcare and the business and commercial models of healthcare, which are all coming together along with a whole load of societal and cultural expectations, both amongst health professionals on the one hand and among patients and the public on the other, and that's all coming together. So let's kind of walk around that kind of
like
quagmire,
a beehive, isn't it, with things moving everywhere.
So what's kind of what might be going on there in different places. A great deal of the time, a lot of what is going on where over-treatment and over-diagnosis, over-prescribing, etc., all these things, where they're happening, I think it is genuinely often happening for the best of intentions, however misguided that might then subsequently turn out to have been. If you like, the core problem in healthcare. So there's the father, really, the grandfather of health economics is a bloke called Kenneth Arrow, who was an American economist in the 50s and 60s, who was really one of the first economists to start looking at healthcare. Who also, very interestingly, was one of the first economists to ever start looking at the environment and environmental problems as well. So a very interesting man.
Wow,
who,
ahead of his time.
We might talk about later, I've seen how some of these these sort of threads link right back to stuff we've actually understood in some ways for a very long time. But he identified very early on, so in the early 60s, that kind of, if you like, one of the fundamental problems of healthcare or defining features of healthcare is, the technical name is what he calls an information asymmetry. But what that simply means is, between a doctor and a patient, why do you as a patient go to a doctor? Well, because a doctor knows more than you do about diseases and what's wrong with people. So we're going in the same way that you take your car to the car mechanic because he knows how to fix it and you don't. You go to the doctor because you might know that you're sick, but you rely on the doctor's knowledge, his or her professional experience and expertise to then get to the bottom of what's going on and recommend, hopefully, what would be an appropriate course of treatment. So we have this imbalance of information, which makes us go to the doctor in the first place. But one of the particular problems as well is that there's another imbalance in that relationship, which is, of course, in the other direction. It's very hard, if not impossible, for the doctor presented with a patient to really understand, well, what do you really want here? Well,
Yes.
and once we're,
There's the mind reader
exactly.
actual body scanning.
I've broken my leg.
Yeah.
Look, that's simple. We'll reset it and put it in a cast, and everybody's happy. There's no ethical dilemmas there. There's nothing complicated going on. But once we get to complex conditions, your cancers, or very difficult and complex conditions, which might require difficult and demanding treatment therapies for people. People have very different views about what do they want, what are really the goals of what they want. The best doctor in the world, as you say, is not a mind reader. They can't get into your mind, whatever your presenting problem is.
And people often do have sort of agendas, even if they're not conscious.
Very complex stuff. So you can't quite know. And even if we're talking about a condition which is actually more straightforward to diagnose, what treatment? There's usually some choices of treatments. What's important to people? That's very hard to get out for people. And at the same time, we're asking our GPs to work in a system, whether it's in Australia or the UK or even in the US, we're asking our GPs to basically do what they need to do in, let's say, 10 minutes.
Yes,
that's how our system works.
Yeah.
So
that's an issue with the system.
You're not
the
exactly.
Time frame.
So how far are you ever really going to get into that? Given that, of course, on any given day, a number of patients are going to turn up and consume 30 minutes each. So everybody else is then being squeezed, squeezed in. So there's all of those kind of communication problems.
Yeah.
One of the deepest problems, which I think is coming out of my research, is that we really struggle as a society and even as individuals between two kind of a real tension. So on the one hand, healthcare, we view healthcare as this amazing technological miracle. We can do these incredible things
that we're very proud of.
And we can do things to keep people alive that even 50 years ago would have seemed inconceivable to doctors. So there's these incredible technologies available, which many of us want the best. And, we live in a world where you can quickly Google all the different options and if you spend long enough, you can find you can find treatment interventions that even your specialist has never heard of,
Yes.
So there's that on the one hand.
Which are probably wrong a lot of the time, but they also could be right because you've got an hour to spend on yourself and he or she doesn't.
Quite right. So there's that, but there's that the draw of the technology and of all the things we might be able to do. But on the other hand, what we all so desperately want as humans is really actually care and caring. That's as much as anything else. That's what we want.
For.
And we are putting, particularly GPs, but also all our other staff, particularly frontline staff, emergency department, doctors, nurses, etc. But GPs bear a lot of the brunt of this because, of course, they're the front door of all health systems. We're putting this incredible conflicting burden on them of look, I want you to work out very efficiently and with absolute precision what's wrong with me, and I want you to give me the best possible treatment, but I also want as much of your time as I need for you to counsel and reassure me and make me feel that I'm cared for and loved. Yeah. And our best health professionals do their very best to try and fulfill both of those needs, but in some ways we're making an impossible ask of them to do those things, especially when, as I say, we're also actually trying to fit that into a 10-minute appointment with a waiting room full of other people waiting outside to get through. It's therefore not a surprise that the simplest option frequently is to write a prescription and get things moving.
People feel like something's been done and the care has been given rather than...
Yeah, exactly.
Yeah, that makes sense.
So that's happening. That happens very frequently.
Yeah.
And even in specialist care, there are
succumbing to pressure
similar
and time
pressures. Yeah, exactly.
Issues,
exactly. When you really look at what the people who can really pay top dollar for private care, frankly, there's no observable difference in the outcomes that any of these doctors achieve. They trained at the same universities. Often, many of them, to be fair, they're operating in the public hospital down the road as well, and they would say that they deliver just the same outcomes in the public hospital as they do in the private. What you're really paying for is their time.
Yes.
And you're paying for much more time with them to talk about options and
to be in a nicer looking room sometimes.
But more than that, to feel, to feel that you are being valued as a patient. And that, that's one of the many pressures. So we've talked. So that's going on. One thing, very interesting psychological research which has been done, which is showing that one of the things that concerns doctors a lot and can often influence their decisions quite heavily is they look at a patient and make their assessment, diagnosis, and thinking about the treatment options. They are often thinking, it turns out from psychological research, they're often really thinking about, well, what would I most regret going wrong here? Here are the courses of actions. If something went wrong, what would I most regret going wrong? And that, very laudable understanding on wanting to avoid making a mistake typically results in them doing more interventions, more investigations, more interventions, doing more stuff for patients than
over-treating,
really,
over-prescribing.
exactly, than really might have been necessary if you looked at it objectively, because they're just thinking about, I want to be covered. Now, there are those, and many doctors say one of the forces that drives them in that direction is actually fear of litigation, medical negligence litigation, and all that sort of thing.
Big fears.
Yeah, so big fears. But interestingly, as I say, a lot of this psychological research suggests that it's more than that. It's actually their own psychological need to minimise the future regret they might have about having made the wrong decision. And that pushes them towards tends to push people towards a more active treatment, very consistent.
Yeah, so not necessarily safe, but active.
Yes, covering more bases. We did more stuff.
It's not saying that they're being reckless.
We've tried to rule out, we'll do these extra tests so that we can rule out X, Y, and Z, which actually probably might be very unlikely, very rare, etc. But so there's a whole lot of stuff. And again, why is that a problem? That's a problem because every time we give you a medication,
someone's paying for it.
Every time we open you up, every time we give you an injection, every time we undertake any sort of procedure
even me just taking a pill,
you're open to some risk of adverse events. So the more things we're doing, that risk goes up in a straight line. Everything we do adds another level of risk to you. Not all the harms of healthcare, absolutely not all of them are due to overtreatment. The best, the best, most appropriate, most necessary care will still carry with it some risk of harm. But the problem with overtreatment, so where you're being treated when you didn't really need it, is that you're still being exposed to all those risks of harm without actually getting the upside of the treatment, because you weren't going to benefit from it.
No, totally.
So that's the real problem there. So it's quite a big source of avoidable harm, as well as a use of resources that we could easily. Well, not easily is the wrong word. It's not easy at all. We could, in principle, at least reduce harm and save and
money.
conserve resources.
Yes. Are there other areas of your research that we haven't discussed, and what is the hope for what is the change or the impact that you're hoping your research is going to make?
Okay. So the other big kind of strand of this research that we haven't talked about that I'm doing, which is I think fairly unique, and very few other people are working on this, is I became quite interested a few years ago, really just outside of health and my day job. I got very interested in environmental things, and the various ecological crises that are unfolding. I mean, particularly climate change, but also all the other problems of biodiversity loss, or you name it, all of these things. As I got interested in that, started to do a bit of digging around and began to think, well, hey, this healthcare must have some part to play in this, and started to do a bit of background research and discovered that there are some people who have been looking at how are health and healthcare and the environment related. So when you start to think about it, first of all, I think most people really have no idea about how big healthcare is. Yeah. Okay, so in Australia, healthcare is
what falls under the banner of it. Yeah.
Healthcare, the industry of healthcare, so all the activity, the kind of formal healthcare sector, is 10% of the economy.
Wow.
Okay, 10% of the Australian economy is constituted by healthcare. In the US, it's
meaning the money that's made out of it?
The money, the value. So statistically speaking, 10% of gross domestic product. So the way we measure the size of the economy in dollar terms, 10% of that is consumed by healthcare or
production,
or is for
the money.
The production of healthcare. Okay. In the US, it's 18%. Okay, so we're fortunate here, but and we're very typical. So most countries like Australia, kind of Canada, UK, Western Europe are in that 9, 10, 11% of GDP is healthcare. That's pretty consistent for those kinds of countries.
Yeah, what is that doing to climate change?
Well, so there you go. So there was a fantastic study. The first study in Australia that's ever been done on this was done a few years ago, and they discovered that using what they call it's a sort of life cycle accounting process, which in a very technical way allocates the carbon footprint of all of the resources going into healthcare. Yep. And the bottom line is that the Australian healthcare system, private and public, is responsible for about 7% of Australia's total greenhouse gas emissions. So it's big. So, and if you think about it, if you've got something which is 10% of the economy, it's going to have an impact. Yeah. And, people go, oh, what's all of that about? Well, look, hospitals are enormously energy-intensive beasts. Yeah. Big buildings that have to be climate controlled continuously with, incredible pieces of electronic kit going on. Yeah. They consume a lot of energy just directly. You think about, so this is not an Australian piece of evidence, but a UK study, I think, found that I think it was something like 9% of all road traffic movements were directly related to healthcare. People going to the doctor, ambulances moving people around, healthcare staff going to work. So it's the sheer size of it means that it's having that impact. Now, some other things that healthcare is doing as well is that, of course, pharmaceuticals unavoidably are made out of fairly unpleasant chemicals. So what we're finding is increasing concern about pharmaceutical pollution of the environment happening at both ends of the system, literally. So there is concern in many countries about release of pollutants from pharmaceutical manufacturing at the manufacturing end.
God, I hadn't even thought about it.
And a lot of that is about how well regulated things are. So it's less less of a problem in a country like Australia. But in India, which is an enormous pharmaceutical manufacturer, there are rivers where you can basically, if you had an infection, you could drink the water out of that river and you'd be receiving close to a full dose of antibiotics because there's just so much coming out.
Yeah.
But even in the rich countries,
that's so weird.
what we can't do anything about is at the other end, most pharmaceuticals, if you take a tablet, all right, for most drugs, something between 30% and 90% of the active ingredients of that dose will pass straight through you and come out of the other end in your urine. Okay, and depending on exactly how the wastewater is being treated, etc., there's quite a lot of drugs which, without spending vast sums on really complicated, kind of unfeasible filtration systems, that then is moving through water treatment plants into the natural environment. So there's some concern about, some evidence that some of those drugs are actually having direct environmental impacts, but even more concern that something we haven't touched on, which is antibiotic resistance and antimicrobial resistance, which is a really big problem around the world, that the problem of antimicrobial resistance might be being compounded by these excretion of drugs and drug pollution out into the natural environment. So there's all kinds of things going on in the healthcare system. Healthcare, uses very resource intensive, using lots of plastics, using, for disposable products, etc. Now, in Australia, these are very safely managed and well looked after. But we're using radioactive materials in healthcare. Yeah. One of the few sectors where we're using sort of quite serious quantities of radioactive materials. Not so much in Australia, but in Brazil, there were horrible incidents a couple of decades ago of radioactive waste from hospitals getting out into the community and causing very nasty cancers and things. So,
who supervises that within Australia?
So I can't remember the name of the agency, but there is an agency responsible for radiological safety, and that sort of stuff is very well regulated in developed countries. But ultimately, that radioactive waste has got to be disposed of somewhere, and we're building it up slowly. So there's all these pathways by which the healthcare system can be having an impact, a negative impact on the environment. When you then combine that, and I guess this was the kind of light bulb that made push me down the work I'm doing, when you combine that with what I've been talking about the overconsumption of healthcare, here we are, if we're over-treating people, giving them more care than they need, we're giving them things that are not going to give them benefit, we're exposing patients to the risk of harm, and we're doing damage to the natural environment all at the same time. Yeah. So there's a whole set of kind of negative impacts that potentially we could eliminate or at least reduce without any harm to patients, because this overconsumption isn't doing anybody any good. Withdrawing over-treatment doesn't hurt anybody. You've saved them money and you've no longer expose them to a risk, but they were never going to benefit from that treatment in the first place. So that's what's really driving me here now, is to think about this, because my view is, whilst environmental policy and climate change remains very vexed in this country and elsewhere, really policies are going to change over the long run. And I think if you look at this stuff closely, it's pretty clear that as a society we're actually going to have to adjust our levels of consumption of everything. It's not just about going green, it's not just about renewables. We're actually just going to have to consume less stuff. And if we have to consume less stuff, well, the obvious place to start is with the stuff that's not doing us any good. Yeah. And I think it's very interesting because when we talk about overconsumption, we all, we tend to think of people with their iPhones and, kind of too many holidays and flying around the world and stuff. And that absolutely, that is all overconsumption that frankly...
But it's human nature to overconsume, so we should apply that to all...
It is. But then the interesting thing in healthcare, and so this is, what makes it very fascinating is that in healthcare, unlike in some other areas of the economy, we're actually beginning to be able to measure and quantify the extent of this overconsumption and then perhaps actually be able to do something about it. So that's what I think is really interesting to me, is how can healthcare actually contribute to reducing the harms that come from healthcare, both to humans and to, the wider environment.
We have to wrap up now, but just as a sort of final, like a takeout, what are you hoping with your research? Like, it's fascinating and it's very thought-provoking and obviously very relevant to health professionals, the government, and me as an individual in my own kind of behaviour. What are you hoping, what do you hope you pass this research on, in 5 years, or what do you hope comes of it?
Okay. So many things, but maybe I'll focus on two, I guess.
Yeah.
Okay. So in the shorter term, I would really like governments, particularly the federal government, but also to some extent state and territory governments in Australia, governments and research funders to do two things. The first, I think, is to take more seriously the problem of overconsumption and overtreatment. There are many fantastic researchers working in this area in Australia, but it's not been as well funded as it should, I think. So I'd like them to focus.
More money, more
I'd like
funding.
them to focus on that, and to recognise that much of our research funding is really focused on, understandably, on developing new technologies, commercialising new technologies, doing more stuff, and to actually recognise that maybe even our research system sometimes can be part of the problem here, and that we need to be investing properly in avoiding overtreatment and being a bit more careful. That needs as much research funding as the new technologies do, or a fair share of the research funding.
Overindulging in new technologies.
So I'd like governments and research funders to take that on. And frankly, I'd like federal government and federal funding agencies to actually start putting some money into proper research on climate change, health and healthcare. So really, for several years, there's been very little funding for research into climate change and environment and health. And I think that needs to change. Longer term, though, what I'd like to be able to contribute to, which is much harder, a much loftier goal, but this is really is to start changing both the health professional and the public culture, and just really get people to start thinking more critically about healthcare, that pretty much like everything else, more is not always better. And that in healthcare, as in all areas of life, there is such a thing as enough. Now, we all might have different ideas about what that enough is, but we actually have to start, as long as we can start from the starting point that there is some level which is sufficient for our needs, and more is not always better. And that's everything from how we're training our health professionals and the kind of environments we're putting them in, where we can actually let them and support them to make decisions to maybe not prescribe that additional drug for the patient. Maybe we'll just see how this one goes, and that would give them a culture where that is the right and the safe and the prudent thing to do, that they'll be rewarded for. But also for us as patients, and not just as patients ourselves, but also when we're supporting our family and loved ones when they are sick, that we also think critically about, is doing everything possible necessarily the best outcome? What do I really want here? And in particular, this is at its hardest, but also its most important towards the end of life, that we really get better. And great work has been done in this area, but there's loads more to do, that we can get better about supporting people to make choices based on really what they want to achieve and what do they want to get out of their last months of life. How can we give them the best quality to do what they want to do rather than necessarily always steering people towards having that last round of experimental chemotherapy or whatever it is, just in case we might do some more. And that's a huge cultural change for us as a whole society.
Yeah, just because it can be done is not necessarily that it should be done. It feels like just everyone's discernment on all ends of it just needs to increase. Fascinating. And thank you so much for doing the work too, because I think it's just so important. And I do hope that episodes like this, like podcasts, that people will start having these conversations and sharing, episodes like this, because that's the way it'll get on the on the rotation out there.
Absolutely.
That leads to the funding and the changes. So thank you very much.
Thank you.
Thanks for joining in the conversation with us about our healthcare system. If you'd like more information on any of the topics or researchers in this series, simply head to iht.deakin.edu.au.